in the interest of time. So, thank you everyone for coming today, and thank you, Sarah, for asking me to do this talk. This is something I don't think we've covered before, but I just wanted to maybe highlight some of the key points about native vessel PCI once a patient has had bypass, and really using a case to demonstrate this. Uh, so we'll just get straight into the case. This is an 81-year-old male who was admitted with a non-STEMI. He had had daily exertional chest pains despite medical therapy. This on a background of hypertension, high lipids, and chronic kidney disease with a baseline creatinine of 190. He had a coronary artery bypass probably about 14, 15 years ago. Lima to LAD, and then a single vein graft to the RPL, which was a Y graft to the diagonal. So in the past, some of the surgeons used to do this. We don't really see this too often these days because they can use remas, they can use radial arteries, and they prefer not to do Y grafts or skip grafts anymore. But in the past, we used to see quite a bit of this. And in 2022, he had an angiogram for angina, which showed severe osteocircumflex disease, critical RCA disease, patent lima, but the vein graft had occluded completely. So then he underwent PCI to his RCA with drug-eluting stents. And then the plan at that time was trial of medical therapy for the circumflex and consider PCI if he has ongoing symptoms. So this was his ECG when he presented. So no obvious ST elevation, so that's why it's an NSTEMI. You have some features there that suggest that he does have some underlying ischemic heart disease, but nothing too acute. So when he came to the cath lab, on the left side you see his native coronary arteries. So the left main, which bifurcates into the LAD and the circumflex artery, and the circumflex gives off an obtuse marginal. And this was the right that had previously been treated with the stent from the proximal to the mid to distal vessel. There's already some signs of early ISR in the right stent, but not more than 50%. So considered mild ISR. The Lima was patent, supplying the LAD. So the question here is what next? And, we have some options. Do we just continue medical therapy? Now, remember, this guy's already on about 3 or 4 anti-anginals, antiplatelet therapy, statin, ezetimibe, antihypertensive, beta blocker. So he's already on significant amount of medical therapy. So that's one consideration. Do we try PCI or redo CABG? And, in an 81-year-old, probably redo CABG is very, very unlikely. But it's something just to think about, especially if you've got someone who's phenotypically very fit, but maybe just advanced in age. So in terms of PCI considerations, we have complex calcified anatomy. You saw that. His ejection fraction was 40%. So the question is, do we need hemodynamic support? We're going to be dealing with very calcified proximal vessels. And then what is the long-term outcome data for this? So this is just a reminder of the anatomy we're going to have to tackle. Remember, this is also a guy with CKD, his advanced age. His hemoglobin was about 10 or 11, so he does fit into the high bleeding risk criteria. The ARC HBR criteria, some of you may know that. I haven't put it in this because we've spoken about it before. But, if you tick one major or 2 minor criteria, age above 75, renal impairment, low hemoglobin, they're all major criteria. Then you would be considered a high bleeding risk individual. So then you might want to think about strategies to mitigate that risk. So what are the options here? We can use compliant or non-compliant balloons. We can use scoring or cutting balloons. Nowadays, we have intravascular lithotripsy and we have atherectomy. One of the things I like to use is coronary imaging to help guide whether whether we should be considering, advanced modification tools for calcium. And the IVIS calcium score it's been published quite some years ago, but it's really quite simple. Is there more than 270 arc in more than 5 millimeters? Do you have any 360 arcs? Do you have a nodule? Is the vessel big? Is the vessel small, less than 3.5 millimeters in diameter? And if you have either of these, you score a point. And then if you got 2, 3, or 4, you should really consider more advanced tools for calcium modification. In terms of atherectomy, just a reminder, you've got some conventional devices, the rotational atherectomy, orbital atherectomy. You also have shockwave these days, which is a balloon-based therapy that's able to modify calcium quite safely without the risk of significant no reflow. At the time when I did this case, Abbott had just bought over Orbital, so they were in the process of rebranding. So I didn't have any access to Orbital. So for me, it was either rotational atherectomy or shockwave. In terms of needing hemodynamic support, you've got patients that have less than 40%. You need to think about all the other criteria. This is the US sort of protected PCI algorithm. I like it because it just, you score a point or two for certain things. And if you got 0 to 2, you're unlikely to need support. If you got more than 4, you should really consider support. So this guy's ejection fraction was about 40. So, oh, sorry, his ejection fraction was normal. So we didn't really need support here. So what is the long-term outcome data with regards to PCI in this cohort of patients? And this is quite a nice paper that actually looked at this cohort and compared it to PCI in the native versus PCI in the grafts. And what you see throughout all the outcome measures, if you do PCI in the natives, the outcomes are usually poorer. Just because of the arteries you're going to be facing, the calcium you're going to have to modify, the complexity of the disease. 1 year mortality was 8.29% when you compared it to PCI in patients that didn't have bypass. So the native in a bypass patient is very different from the native in a non-bypass patient. And then with regards to grafts are usually simpler, straightforward, but they're not durable. And this guy, we know his graft has been occluded for 2 or 3 years now. So you're going to have very, very slim chance of opening that up and then keeping it open. And this just kind of shows what I've just mentioned there. So the black line demonstrates on the left graph bypass, and then in the red line you've got no bypass, and really the cumulative incidence of all-cause mortality is much higher if you have bypass. Same for PCI. The curves start to separate as you move away from the time of your bypass. And we know that if you do PCI in the native graft, in the native vessel, it tends to be harder to do. It tends to require a lot more contrast, a lot more equipment, but it's more durable. So whenever feasible, native coronary artery PCI should be prioritized treatment for saphenous vein graft failure, rather than reopening the blocked vein graft, because even if you get a fantastic angiographic effort, it's not going to be a durable one. So I decided to treat the native. So you can see here, this is for guide support, so that I can get equipment into the circumflex. Just putting an anchor wire in the LAD to anchor the guide, and you can see how the anchor wire traverses. And then proceeding on to wire the circumflex, which surprisingly went quite easily. So once we got down, then this is a 125 balloon, and the 125 balloon cannot cross. Trying to anchor it and see if we can get across with an anchor. Remember, the LAD is supplied by the Lima, so it's what we call protected, and this is protected PCI. So you can anchor in the proximal LAD there, but even then it was tricky. So used a guide extension catheter, and then finally managed to get the the small balloon across so that we can put the IVUS. And this was the IVUS that I did. So this is a Opticross 60 megahertz IVUS. You can see, quite significant calcification here. We have nodule. In the beginning, we had arcs of 180, 270 degree. So the question here is, and I might pause it here to poll some of the audience. Do we do rotablation now, or what do you think? How do we approach the calcium that we see here in a post-bypass patient?
Bharat, let it run, please, again, the IVUS.
Yeah, I'll just go one back.
Okay, Ahmed, thoughts? What would you do here?
I'm sorry?
What would you do here? Would you use, so the balloon, the 1.25 crossed with a guide liner, or Guidezilla, whatever, and then the IVUS crossed. What would you do here to prepare the lesion?
Well, I'm sorry to say that I'm not really experienced in dealing with such lesions as a resident.
Okay, that's fine. And Leo?
I don't know if you can hear me. I have a very bad bronchitis.
Very sexy voice, Leo. Very sexy.
Very sexy. No, please don't speak.
I'm not feeling so sexy.
It's enough. So let's go ahead. Oh, do you want to speak? I don't want to push.
I'm gonna try. I think for the distal lesion, I will rotablate. It's too much calcium.
No, I mean for the circ.
Yes.
You would use rota in this case.
I will start with rotablation, yes, and after that I will repeat the IVUS, and probably I will do also lithotripsy. It's more than 180 degrees calcium, and this pretty thick.
Which burr would you use?
1.5, probably 1.5.
Okay, you have a 6 French here, Bharat?
Yeah, I think this one is a 6 French, yeah.
6 French, okay. Different thoughts from Ibrahim. Jazim just joined, so probably didn't see the case. Ibrahim, Iman, you have different thoughts?
I agree with Leo. Rotablation with 1.5, can use it with 6 French. And maybe also IVL if we need to optimize more.
Okay. And Ibrahim? Amit, any different thoughts?
Hi, Professor. Good evening.
Hi, Amit.
We can use orbital atherectomy also.
But which would be your strategy here? What would you use?
Rotablation with 1.5 bar.
Okay. So it seems that the majority would go rota with 1.5.
Yeah, I think that's a good thought. One of the concerns for me, I don't know if Amit, you may have seen it, but I might bring it back. Just the angulation there. I'm just a bit concerned getting into the circ. And if you look at in the spider view, it actually doesn't. I mean, there is calcium there, but I think the balloon couldn't deliver just because the proximal circumflex you kind of bent around. And once we got the guide extension just into the proximal circumflex, actually, the balloon went easy, the IVUS went very easy. So I actually thought just go with the balloon-based strategy.
So which is your concern for rota here, for the bending?
For the bending, yeah, you see where I've highlighted there, because this we've only pre-dilated with a small balloon.
Yeah.
And my
You
worry
use the
is
125, no? At this
1.25.
moment.
Yeah.
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 But which is your concern as related to the bending? Which
So
your
the
fear is
worry
to perforate or what?
perforate. Yeah. The worry is perforation. I mean, if I had orbital in this case, maybe I would minor in and then do ablation maybe one way or the other. But I think just with rotablation, I worry it hugs the outer curve and then we
Yeah,
perforate
yeah.
because most of the calcium is on the inner curve, towards the circumflex side.
Yeah.
And
But do you think that, okay, if you fear to perforate here, your fear, I think, would be to perforate at after the bending, in the circ.
yeah,
No? Yeah.
just after where it goes into the proximal circ.
Yeah, after the white. Okay, after the
Yeah.
white. Yeah. Okay, but there you wouldn't have calcium. You would have normal,
Soft.
soft
Yeah.
tissue. So you think that the burr, a small burr, would
Yeah.
perforate there? Okay.
Yeah, maybe not. I think maybe not because actually once I started ballooning, yeah, you're right. It actually behaved like a fibrous, non-calcified plaque. So I'll show you what I did. So this is
what
after.
you said. No, what you said is, I think it's why. If you fear to perforate, you can always adopt a stepwise strategy using something different, see how the vessel behaves,
Yeah.
and then come back on your decision.
Yeah.
Please.
So this was after sort of compliant, and then I think it was a 2.5 non-compliant, and then eventually a shockwave 3.0. I don't know, is it playing weirdly on your screen?
It's playing. It's playing, but here you use a compliant, non-compliant, and score flex.
Yeah, more for the distal. So a 2.0 score flex in the distal, and then
Okay.
proximal is a 2.5 NC before a 3.0 shockwave.
It will be interesting to see how is the lesion preparation before shockwave. Don't know if you have it.
I don't know if I have the IVUS. I don't think I put the IVUS here.
Okay.
So what I
Okay,
did
so you thought that it was not enough as a lesion preparation, but it was enough to deliver the shockwave, and then you deliver a 3.0 shockwave.
correct. Yeah.
Okay.
So
Okay.
then proceeded to do a hybrid strategy. So a stent proximally, and then a drug-coated balloon or two drug-coated balloon, one into the OM and one into the mid-circumflex. And the balloons expanded relatively nicely. And then proceeded to secure the sort of the left main to proximal circumflex with a single stent. So we got away with one stent, two drug-coated balloon, and achieve some type B dissection distally, but TIMI3 flow. And
can we see the IVUS for the expansion of the stent?
yeah, let me see. Yeah, so I don't think I put the actual run in, but this is the proximal, the calcified lesion just at the bifurcation, the left main, and then the distal.
Yeah, so MLA is 10.5 at C. That's the end of the stent.
10.54. Yes, 10.54. And then in mid stent, so in the sort of just inside the left main, in the distal left main is 13.5, and then the proximal stent is 17.
That's excellent. Excellent result.
So, you do get you don't get symmetrical, result, but you get 10.54. I think the expansion's good. It's well opposed. I think it's a nice result. So, I mean, the QFR is not validated yet. We were sort of collecting data for QFR in left main to LAD or left main to circumflex. Most of the QFR data is sort of proximal LAD, proximal RCA, proximal circumflex. So this was just a small audit study that we were doing. So the QFR, when you look at it, was 0.97. So
you wanted to spend more money.
no, it's free. We can use
The
it as
QFR. You don't pay
so
for
for
it?
us. No, because we get it on a rental. So it's we pay a monthly fee, and then we can do
nice.
we can do every case.
So you don't pay for the usage,
No,
but
our
just for the
radiographer does
rental.
it. Yeah, we just pay a
That's
monthly rental, and our radiographer does it. So we train the cardiac technician and the radiographer, and they just do it. So, if you want,
you know something. I don't know if there is any study done with angio-derived, like QFR, MUFR, and intravascular imaging. Are you aware of any study? To find the correlation between the cutoff of the MLA in each specific segment and the result of the physiology, angio-derived physiology.
yeah, it's a good point. I can't think
I'm not
of
aware
yeah.
of this study. Is any one of you aware of such a study?
No, there is no study. I looked only recently for this because I was reviewing a paper for cutoff for the pressure wire using this QFR. I could not find anything which correlate with the IVUS.
That would be interesting because, Bharat, you have a lot of cases done. You use a lot of intravascular imaging. We can, what do you think? We can put somebody to see how many cases you have and do a study on that, retrospective one, I mean.
And so you'd be looking at what how
So
would
it's
you-
MSA, MSA
Yeah.
versus the QFR. Basically, it's like
at the point of the lesion.
yeah.
Yeah, of course, the minimal stent area is variable according to the segment. So we cannot put together left main with distal circ, of course.
Yeah.
But we can create a good database and see what numbers bring. It's a quite novel finding.
How many
You already have the data.
How many patients do you have, Bharat?
For QFR?
Yeah.
I mean, I can retrospectively just do like all we do is just pull the angio and do 2 frames, and we can do it. Like it takes the radiographer or the tech like 2.5 minutes to do one.
And
But,
you have it since when? Since when do you have it?
QFR we got about 3 years ago. So 2020.
Oh my God.
2022.
So you have thousands of cases.
Yeah. Because for all my presentation, if I want to have a QFR, I can just retrospectively go back and do it.
So you have thousands of cases, and so the limitation here is how many intravascular imaging do you have?
Yeah, I mean, IVUS we would have quite a bit. Yeah,
we could do a pilot study on a vessel like the LAD, for example. See how many IVUS or OCT you have for the LAD,
and
correlate.
Don't you think left main? Because we know that we have clear cutoff for left main, and we can look mostly for the left main, IVUS or CT, and we can see the LAD and also circumflex. However, Bharat, we have a lot of cases, has a lot of cases, but it will take a lot of time to do it, to prepare it. And it is possible maybe to do it offline, like because it's impossible to do everything by you, Bharat. So
yeah, so I mean the question is we can do a few and then see whether it's feasible.
Exactly.
Like just to get before we embark on it, just see whether it's something.
We can select a segment, like could be distal left main, could be proximal LAD. Yeah, and then do it. Yeah. Bharat, do you want to spend some time to see how many imaging you have for distal left main? And then, that's a good idea, I think.
Yeah, okay.
All right. Okay,
so in summary,
please.
that's okay. We had successful IVL-assisted IVUS-guided PCI to the proximal left main to mid OM with the hybrid DES DCB approach, using a single stent, post-dilated, and then overlapping drug-coated balloons. He was actually discharged after 2 days and was seen at 6 weeks. He's been doing well, no chest pain, good exercise tolerance, and tolerating and adhering to all his medicines. So in terms of take-home messages, the PCI of native vessels post-CABG can be challenging, with calcified and diffuse disease frequently encountered. Calcium modification techniques are frequently required. Image guidance nowadays, when you do complex PCI, it's really important to use image guidance, and then consider hybrid DS-DCB approach. I guess in retrospect, yes, maybe we would have got a better result with rotablation, but I guess now with IVL, we can get away with a balloon-based strategy that hopefully is durable. I mean, the patient's symptom-free at the moment. So,
but you see, my concern here is the acute results great, maybe in 6 months also okay, but as the time goes by, there's a high chance of ISR in that area because the combination of two, one is the angulation, all the stent fatigue, whatever, but also I think there might be a nodular calcium in that, which probably might erupt again. So I think going forward, I think I use a lot of rotablation for these kind of ostial circ left main in the post bypass because especially this wire bias, and you need at least 175 burr. Sometimes 2 because you need a lot of debulking in that area and spend time. Even with that, you have ISR. So I don't know.
Yeah, and with these nodules, no matter what you do, I mean, they tend to come back.
Yeah. But it's a nice case. I only came in the halfway through. I was just doing a case. We just finished a rota and stuff like that. Just
okay, that's it.
Nice
well done.
case. Thank you.
Nice.